Diabetes mellitus is one disease where you really owe it to yourself and all your future patients to learn about it in its entirety. While the root cause of the problem is decreased insulin activity, meaning fat, protein, and carbohydrate metabolism is altered, the majority of the complications of diabetes are from elevated blood glucose. So why do people lose their insulin activity? Y'all know about the type 1 diabetics who lose their ability to produce insulin, and the type 2 diabetics who develop insulin resistance over their lifetimes. There's also gestational diabetes, which happens to pregnant women, but you'll learn more about that in the repro section. Diabetes mellitus is often caught at its asymptomatic stages because of good screening, but the earliest symptoms in the acute stage tend to be pretty similar to diabetes insipidus, polyuria and polydipsia. But while diabetes insipidus was an inability to hormonally control the kidneys, diabetes mellitus involves forcibly dragging water into the urine because of the sheer volume of glucose that's present inside it. Another common symptom is polyphagia or constant hunger, because while there are plenty of nutrients being circulated around the body, they can't get into the cells. And as a result of the increased catabolism and water loss, patients with diabetes may actually lose weight, particularly patients with the more acute type 1 diabetes. Now, what other disorder, by the way, is known for causing weight loss despite eating more? The answer is hyperthyroidism, and actually this combination is a lot more representative of hyperthyroidism than diabetes. But since it does happen in a handful of initial presentations, just keep that in mind before you see polyphagia and weight loss and immediately jump to hyperthyroidism. Maybe think a couple more steps down the line. But again, the majority of diabetes is asymptomatic upon initial detection, and it's usually only after finding a blood glucose of 300 that patients are like, oh yeah, now that you mention it, I guess I have been peeing more than usual. The really high-yield stuff is the complications of chronically elevated blood glucose. One of the main complications is caused by the fact that while glucose is an awesome source of ATP-generating energy, it has the really unfortunate tendency to react spontaneously with and bind to amine groups, which is unfortunate because amine groups are found literally all over the body, in almost every kind of protein. They irreversibly bind to the proteins, at which point they can cause all kinds of shenanigans. They can cross-link to other proteins, disrupting the structure of the tissue. They can oxidize nearby molecules because of their chemical reactivity. And certain cells, such as macrophages and endothelial cells, go absolutely insane trying to eradicate glycated proteins, causing inflammatory reactions all over the body. Non-enzymatic glycation leads to two major categories of disease complication: macrovascular and microvascular. Macrovascular disease basically refers to atherosclerosis of the major arteries, and diabetes is really one of the most important risk factors for this. Depending on which vessel is affected, this can lead to a wide range of complications. Just to review, which arteries most commonly get clogged in large vessel disease? In order, the abdominal aorta is most affected, which predisposes to aneurysms, dissection, and plaque rupture, which can lead to distal embolization. Coronary artery disease, which is actually the leading cause of death in diabetic patients, is the next most common. And we all know that CAD causes chest pain and at worst myocardial infarction. Peripheral vascular disease includes disease of the popliteal and iliac vessels, and what does that one lead to? This guy causes claudication and contributes to the poor wound healing and even gangrene that you see on diabetic feet. Finally, you got carotid artery disease, and what's the major complication of this? Among other things, carotid plaques can rupture, embolize, and cause a stroke. Microvascular disease affects arterioles, capillaries, and venules, and involves totally different pathogenesis than macrovascular disease. The glycation causes extensive thickening of the basement membrane, which narrows the vessels and obstructs blood flow. At the same time, these thickened vessels get stiff and, for lack of a better word, crunchy, so they break really easily. This fragility can lead to hemorrhage and also abnormal protein leak. Now, the most important microvascular complications to know are retinopathy, nephropathy, and neuropathy. Diabetic retinopathy can involve a range of signs that you see on fundoscopic exam, from exudates to hemorrhage, and is one of the most common causes of blindness in the US. Diabetic nephropathy, which you'll learn about more in renal, is an extremely common cause of chronic kidney disease, but can cause protein leak and hypertension years before the renal failure occurs. And finally, diabetic neuropathy is an important contributor to the development of diabetic foot ulcers, and is partially caused by microvascular disease of the small vessels that supply the nerves. If you can't feel your feet, then you can't feel the pain of a festering wound from stubbing your toe last week. It can not only cause the loss of sensation and pain, But it can also affect the peripheral autonomic nerves, causing things like gastroparesis, constipation, and urinary incontinence. The other cause of neuropathy is physiologically pretty interesting. It's something you learned about in biochem. Osmotic damage is something that has nothing to do with non-enzymatic glycation. It results from a neat trick developed to trap glucose. By converting glucose to the sugar alcohol sorbitol, glucose can continue to be imported in without building up a concentration gradient inside the cell that prevents future transport. Which is fine under normal circumstances, but unfortunately, sorbitol can't leave the cell unless it's converted by sorbitol dehydrogenase. And some of these cells are unable to do so, meaning that in cases of severe hyperglycemia, buildup of sorbitol can't be metabolized quickly enough and causes damage by drawing water into the cells, making them swell up. The specific kinds of cells that are affected are the Schwann cells, which contribute to peripheral neuropathy, and the cells of the lens, which lead to cataracts. So, take a look at all that for a moment. It's a lot. And not only that, most of these complications require specialist-level knowledge to adequately treat, from vascular surgeons to cardiologists to ophthalmologists, and like a complete tool, I just blurted out an oversimplified laundry list of complications to you and said, have fun memorizing. Look, I'll be the first to admit that there's a lot more you have to know about most of these than what I just told you. But my purpose here in endocrinology is to organize the complications of diabetes into a logical flowchart so that when you see a vignette that says past medical history of diabetes, which is half of them, you will know what complications to expect. Now that you guys have this context, I encourage you all to stop the video right here and briefly look over some of these disease processes to help build the mental connections from diabetes to other complicated diseases, such as atherosclerosis, coronary artery disease in the cardiovascular section, stroke in the neurology section, and diabetic nephropathy and chronic kidney disease in the renal section. It's always better to reinforce the connections between these subjects rather than learning about them in a vacuum, so take the time to do this, and restart the video once you're done. The most intuitive way to diagnose diabetes mellitus is by measuring blood glucose, but it actually varies quite a bit based on when you last ate. Your blood glucose goes slowly down when you've been fasting, spikes briefly after a meal, and in a matter of a couple of hours or so, goes back down to baseline. You can use this knowledge to make the diagnosis of diabetes mellitus in 3 different ways. Most reliably, if the patient's fasting glucose is greater than 126 mg per deciliter. You can also measure a patient's glucose 2 hours after a standardized oral glucose load, and if it's greater than 200, you've got yourself some diabetes. Finally, if a randomly drawn blood glucose is greater than 200 and is accompanied by symptoms like polyuria and polydipsia, you've got yourself some diabetes. Now, blood glucose is one way to do it, but either way, you're only really assessing the person's sugar at a specific point in time. Now, is there a way to assess the degree of ongoing glucose elevation? As a matter of fact, the glycated hemoglobin we were referring to earlier does just that. Since red blood cells turn over every 120 days, the percentage of glycated hemoglobin at any given time is a reflection of the amount of glucose elevation that's been going on during that time. Now, this is particularly good for patients who try to pretend that they've been good by, shooting a mega dose of insulin before their lab work. It's usually those type 1 diabetic kids. Because while they're going to acutely decrease their glucose, the HbA1c will still be there until those cells cycle out of the body 3 months later. A value of 6.5 or higher is enough to diagnose diabetes. While the sequelae of elevated blood glucose are the same no matter what type of diabetes you have, there are a lot of important differences between type 1 and type 2 diabetes that you have to know for the test. Type 1 is a simple autoimmune destruction of the beta cells, a lot like any other autoimmune glandular dysfunction. Basically, the islets of Langerhans are infiltrated by leukocytes that destroy the beta cells and completely wipe out insulin production over a matter of months. What about type 2 diabetes? If you said insulin resistance, that's part of it. In fact, to be fair, that's what initiates the disease, so you're mostly correct. A complex set of hormonal events, usually triggered by obesity, causes progressive insulin resistance that initially causes the hyperglycemia. The beta cells actually try to compensate for this by cranking up the insulin, but hyperglycemia causes progressive damage to the beta cells by inducing amyloid deposition in the islets. So at a certain point, not only is their insulin resistance impaired, but the insulin secretion is diminished as well. Now, if I were to ask you which type of diabetes was the most genetically predisposed, which would you guess? A lot of people would probably guess type 1 because we're all trained to think of the type 2 diabetics as the fat, lazy ones, and by default the ones who are responsible for their own disease. But as it turns out, type 2 actually has a stronger genetic predisposition than type 1 diabetes. Type 1, like a lot of other autoimmune diseases though, is associated with a couple of specific HLA subtypes, HLA-DR3 and HLA-DR4. Man, I hate those HLA subtypes. Let's talk a little bit about how these diseases present. Type 1 diabetes is often known as childhood onset, and type 2 is sometimes called adult onset, but there's a huge amount of overlap, especially with as much childhood and teenage obesity as there is today. In general, though, type 1 diabetes first becomes symptomatic before age 30, whereas type 2 diabetics become symptomatic usually after age 40. The initial presentation of a type 1 diabetic is almost always more dramatic than type 2. Because the onset of their disease is subacute rather than chronic, they'll experience the classic polyuria, polydipsia, polyphagia, and weight loss a lot more frequently. Many of them come in with diabetic ketoacidosis, which we'll talk about in a moment. In contrast, most type 2 diabetics are discovered either during screening or during an accidental glucose test. They're asymptomatic at the time of diagnosis. Because they do have some insulin function, they usually don't have the same problems with ketoacidosis, which, by the way, only happens when the body's cells are severely deprived of glucose uptake. So, how would you treat type 1 diabetes? This one's a lot more straightforward. They're not producing insulin, so basically, you give them insulin. How about type 2? Well, because type 2 diabetes doesn't present with a crisis, and because it's connected to obesity, diet and exercise are generally the first line. If the diabetes persists, oral agents and even insulin may be employed to close the gap between insulin resistance and insulin availability.
Diabetic ketoacidosis, or DKA, occurs when the metabolic consequences of diabetes, usually type 1, come together at a critical mass and can actually kill the patient. This is actually not uncommon for a first presentation for new diabetics who don't know they've got it, but it's usually precipitated by an illness. Now, why would an illness exacerbate a person's diabetes? One reason is that when the body's under stress, that's when the anti-insulin hormones like cortisol and epinephrine ramp up. So the patient needs more insulin for normal metabolism, but they can't get any because their pancreas is kaput. The other reason is much simpler. A lot of people are non-compliant with their meds. Now, before you get pissed at them though, remember that while non-compliance can stem from being irresponsible, it's often because patients can't afford their medication.
Diabetic ketoacidosis is a syndrome that essentially stems from three major issues. First, the patient will almost certainly come in dehydrated. Why? Because the increased blood glucose also leads to increased glucose in the urine and subsequently increased water loss via osmosis. Second, patients with diabetes come in with anion gap metabolic acidosis. If you like mnemonics, DKA is the D in mud piles. Remember insulin's effects on fat metabolism? Well, the lack of insulin means that in DKA, patients are pushed towards fat catabolism and ketone body production. Now, while ketones make a decent circulating energy source, their acidity makes them pretty problematic in high concentrations. Now, side note, interestingly enough, while type 2 diabetics may present with extreme hyperglycemia and dehydration, they rarely present with ketoacidosis. The interesting thing is, it takes a lot less insulin to suppress lipolysis than it does to promote glucose uptake into cells. And type 2 diabetics, by and large, have some insulin function, unlike the type 1 diabetics, who have none. Finally, one of the other major problems the patients present with is potassium abnormalities. Now, this is not quite as intuitive, so I'll go over the physiology. First, where's potassium primarily located in the body? It's primarily an intracellular ion, and the constant influx of potassium ions is normally supported by insulin. Without sufficient insulin, potassium ions move into the extracellular space. But here's the interesting thing. As a result of the dehydration, aldosterone's also going to be operating at extremely high levels, and what do you think that's going to do to the potassium? It's going to cause total body loss of potassium into the urine, which leads to a very interesting potassium situation. While a patient can present with hyperkalemia from insulin deficiency and dehydration, the fact is their total body potassium is actually depleted. We'll talk about why this is in a moment, but trust me, it's majorly important.
Finally, one of the other major problems patients present with is potassium abnormality. Now, that's not quite as intuitive, so I'll go over the physiology. First, where is potassium primarily located in the body? Potassium is primarily an intracellular ion, and the constant influx of potassium ions is normally supported by insulin. And without sufficient insulin, potassium ions move into the extracellular compartment. Now, here's the interesting thing. Because glucose acts as a diuretic and makes you excrete ungodly amounts of urine, you also lose a ton of electrolytes, including potassium. Now, the kidney is usually smart enough to try to retain the electrolytes when it senses that blood levels aren't where they're supposed to be. But as a result of the dehydration, aldosterone is also going to be operating at extremely high levels. So, what do you think that's going to do to the potassium? It's going to cause a loss of total body potassium into the urine, which leads to a very interesting potassium situation. While the patient can present with hyperkalemia from their insulin deficiency, the fact is their total body potassium is depleted. We'll talk about why that's important, but trust me, it's majorly important.
The signs and symptoms and complications of DKA are all related to these three pathophysiologic components of the disease, but it's the acidosis that leads to the most characteristic symptoms. First, how does the body compensate for metabolic acidosis? Through hyperventilation, and in the case of DKA, you see very rapid and deep breaths called Kussmaul respirations. Also characteristic of DKA is severe nonspecific epigastric pain, nausea and vomiting, and the smell of acetone on the breath. Now the vignettes might describe it as fruity or like pear drops, but to me acetone doesn't really smell like either of those. The entire cocktail of metabolic abnormalities will usually have the patient presenting with CNS complications such as delirium, psychosis, or even coma, and with cardiac arrhythmias that can lead to heart failure. One pretty unique complication of DKA is mucormycosis, and you remember that one from Micro? It's the face-eating fungus whose favorite food just happens to be ketones and sugar, and whose favorite environment just happens to be slightly acidic. This is a big deal, and not just because you need your face to stay beautiful. This disease spreads surprisingly fast and is more than capable of penetrating from the skull into the brain. Be thinking of acute fungal sinusitis if your patient in DKA develops facial symptoms like orbital swelling or any cranial neuropathies. We'll talk more about this in the microsecond, but just remember, this is an emergency and requires surgical debridement, no mucking around with antifungals. You should be able to recognize diabetic ketoacidosis from the labs as well, because they're pretty distinctive. You can predict these lab values from the three major metabolic abnormalities demonstrated on the right. Hyperglycemia, which increases the osmolality of the serum and urine, is the cause of the dehydration. In fact, serum osmolality is so high that you get a dilutional effect on serum sodium. If they give you an arterial blood gas, you'll be able to see that the pH is decreased, but more often than not, you'll see decreased bicarb because it's metabolic acidosis. You'll definitely see ketones in the serum and urine as well. Finally, you may see hyperkalemia in your patient when they first present, but it's very important to look for because it can seriously increase your risk of cardiac arrhythmias, and it affects the treatment, as you'll see in a moment. So first of all, what's the most important thing to give to a patient in DKA? All you people who said insulin, by the way, are wrong, but don't feel bad because almost everyone got this wrong in my third year as well. By far the most important thing to give is fluids. IV normal saline to be precise. Believe it or not, hypovolemia and hyperosmolality from all that glucose are far more lethal in these patients than acidosis. Aggressive hydration will not only fix these issues quickly, but also provide sufficient fluid for the kidneys to correct the rest of the abnormalities. Of course, you're going to want to start the patient on IV insulin to fix the underlying issues of hyperglycemia and ketoacidosis. Subcutaneous insulin would take too long to titrate, so you definitely want a continuous IV drip here so that you can follow the body's response. Finally, remember how I was telling you that while serum potassium was concentrated, the total body potassium was actually pretty low? Well, once the insulin and fluids are on board, the cells are going to be like, thanks, but now I want my potassium back. Unfortunately, a lot of it's now in your pee, and unless you feel like drinking that, you're never going to get it back. What happens then is, the potassium moves back into the cells and completely depletes the serum potassium if you're not watching that lab value like a hawk. So you got to have IV potassium on hand and be ready to replace their potassium whenever necessary.
Hyperosmolar hyperglycemic non-ketotic syndrome is another critical culmination of diabetes, and this one usually occurs with type 2 diabetics. And unlike DKA, this condition is almost always caused by extended medication noncompliance or totally uncontrolled diabetes. Now here's the deal with this syndrome. Abbreviated HHS or HHNS. While DKA involves a trifecta of dehydration, acidosis, and potassium disruption, remember that even a small amount of insulin activity is enough to prevent significant ketogenesis. Most type 2 diabetics have enough insulin reserve to stave this off for a while, meaning they don't typically become acidotic. Now here's the thing. Most of the early symptoms of DKA are caused by acidosis. Both blood sugar and acid levels increase gradually until the acidosis causes significant symptoms. Then they come in, get treated, and move on with their lives. With HHS, there's virtually no acidosis. Patients' blood sugars can rise to insane levels before they start to feel sick. So, while these conditions are related, the focus of the problems is quite different. Because the blood sugar is so much higher, the dehydration is typically much worse. Contrary to what the name would suggest, severe dehydration can actually lead to mild ketosis, which is why some people just call this HHS instead of HHNS. But the bigger issue is that with a glucose over 600, and commonly in the thousands, the serum osmolarity gets tremendously high. And as the section on SI88 should have taught you, bad things happen when your osmolarity gets out of whack. The symptoms are mostly neurological, progressing from lethargy all the way to coma and cerebral edema. This is actually a lot more dangerous than acidosis. The mortality for this state is 10 to 20%, compared to a measly 2 to 5% for DKA. It should make sense that the treatment is largely the same as for DKA, except that these patients often need a lot more volume resuscitation, and the end goal of their treatment is to normalize their osmolarity, rather than to close the anion gap. So that about covers it for diabetes, but I have to reiterate, diabetes is a super important disease. But part of why it's so important is because it's connected to so many other high-yield diseases. If you haven't done so already, take a moment to look over some of the related diseases, such as atherosclerosis and coronary artery disease in the cardiovascular section, stroke in the neurology section, and diabetic nephropathy and chronic kidney disease in the renal section. But for now, we're going to wrap this one up with a flash quiz.
True or false? Diabetes mellitus may lead to coronary artery disease, stroke, chronic kidney disease, obesity, and dehydration in the long term. Go ahead and pause the video if you need more time to think. Okay, this was a bit of a mean question. So actually, while most of these are either long-term or short-term sequelae of diabetes, the answer is false. Because obesity is not caused by diabetes. It's actually the other way around, even though this is counterintuitive. Obesity is a risk factor for type 2 diabetes, but if you think about it physiologically, insulin resistance means you're losing the anabolic effect of the fed state. That means you're less likely to store nutrients as glycogen or fat, plus you're peeing out all your calories as syrupy sweet urine. So really, diabetes is more likely to lead to weight loss in the long run, even though it's mostly obese people that get type 2 diabetes. But make no mistake though, all the others that I mentioned here are bona fide sequelae of diabetes.